Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Pretest: which of the following best describes the primary clinical utility of the coronary artery calcium score in cardiovascular risk assessment? A. Identifies and quantifies both calcified and non-calcified plaque in coronary arteries. B. Predicts future atherosclerotic cardiovascular disease events and improves risk stratification. C. Replaces traditional risk factors such as serum cholesterol, blood pressure, and diabetes in the management of atherosclerotic cardiovascular disease. D. Determines the need for revascularization in symptomatic patients. What is coronary artery calcium? Coronary plaque consists of calcified and non-calcified material. Cardiac CT detects coronary artery calcium, measuring the burden of calcified atherosclerosis. Coronary artery calcium increases with age. 80% of individuals above the age of 80 years have coronary artery calcium. Agatston score quantifies coronary artery calcium from 0, that is none, to greater than 1000, extensive disease. Higher coronary artery calcium is equivalent to higher cardiovascular risk. Clinical significance of coronary artery calcium: strong predictor of atherosclerotic cardiovascular disease events such as myocardial infarction, stroke, and cardiac arrest. In the MESA study, a coronary artery calcium greater than 300, the 10-year atherosclerotic cardiovascular disease risk was double digits and more, 13.1% to 25.6%. For every two-fold increase in coronary artery calcium, there was a double digit, that is 14% increased risk of atherosclerotic cardiovascular disease. Coronary artery calcium of 0 is associated with low atherosclerotic cardiovascular disease risk, even in those eligible for statins. High negative predictive value. If coronary artery calcium equals 0, the likelihood of major cardiovascular events over the next 5 to 10 years is very low. Coronary artery calcium and risk stratification. The MESA risk score integrates coronary artery calcium with traditional risk factors such as age, cholesterol, hypertension, etc. There is improved risk discrimination, a C statistic of 0.80 versus 0.75. The ACC, that's the American College of Cardiology, American Heart Association guidelines, recommend a coronary artery calcium testing for individuals 40 to 75 years with an intermediate atherosclerotic cardiovascular disease risk of 7.5 to 20%, while for decision making for statin therapy in borderline risk patients, a coronary artery calcium greater than 100 or a coronary artery calcium greater than 75th percentile is associated with a strong recommendation to initiate statin therapy. Practical considerations and cost. Coronary artery calcium testing costs $50 to $400, not covered by Medicare and most insurance companies. Self-referral is increasing. The need to study impact on risk stratification. There are downstream testing concerns regarding this being followed up with stress test and angiography. Repeat coronary artery calcium testing is not advised once statin therapy is initiated. Summary and key takeaways. Coronary artery calcium testing enhances atherosclerotic cardiovascular disease risk, useful for borderline and intermediate risk individuals considering statin therapy. High coronary artery calcium predicts cardiovascular events, while coronary artery calcium of 0 equals low risk. It supports personalized prevention and precision medicine. More research is needed on self-referral and cost effectiveness. You can read more in a recently published JAMA Insight article titled Cardiac CT Calcium Score. The lead author is Peter Glynn, the middle author is Dr. Sadia Khan, and the last author is Dr. Philip Greenland. Published March 5th, online on JAMA. Post-test, which of the following best describes the primary clinical utility of coronary artery calcium score in cardiovascular risk assessment? The correct answer was B. It predicts future atherosclerotic cardiovascular disease events and improves risk stratification. The coronary artery calcium score measured using cardiac CT quantifies calcified coronary atherosclerosis and has been shown in studies like the MESA study to improve cardiovascular risk prediction beyond traditional risk factors. A coronary artery calcium score of 0 is associated with very low 10-year risk of atherosclerotic cardiovascular disease, while higher scores greater than 100 correlate with increased likelihood of future cardiovascular events. Coronary artery calcium testing is particularly useful for borderline or intermediate risk individuals, which helps to guide statin therapy decisions.